Hello. So unfortunately, I'm not tech savvy and I do not know how to record anything on Google Slides. So this is why I'm making this. Enjoy. So this is the portion, excuse me, A through C. This is Brenda Lynn, by the way. So here we go. This is the RUA case study for sickle cell disease. So to start, the patient I have is AG. She's a 25-year-old African-American female. She weighs 54.4 kilograms and she's 167 centimeters. AG came into the emergency room complaining of severe chest pain and stated that she had a hard time catching her breath. Upon arrival, there was a general assessment done and she was tachypnic and her body was tense along with her skin being pallor. Upon further assessment, AG stated that she just finished college and she started a new job a week ago, so she's pretty stressed out. She said that she's been feeling tired and had a slight cough starting a few days ago that has progressively gotten worse. She stated that now her chest pain feels like it's a stabbing pain, and as of yesterday, she started coughing up quite a bit of phlegm. So in her past medical history, AG was diagnosed with sickle cell disease at the age of 4 and had 8 previous hospital visits in the last 10 years. She was admitted twice for the development of acute chest syndrome and required blood transfusions on both occasions. She informed the nurse that she takes ibuprofen for mild pain. She also has a prescription for slow and immediate release morphine sulfate for moderate to severe pain that she doesn't take unless she absolutely needs it, and folic acid for maintenance. AG was able to get to the hospital because her mother was there and will be taking her home upon discharge. So like I said, her mother is the one that took her to the emergency room. Her mother is healthy as well as her father. She also has 2 brothers, all of which live in the same area. So they get together and they're a close-knit family, and she'll have support once she's discharged. She has no known allergies, and is a full code. They got her vitals upon arrival, and her pain was a 10 out of 10, and all of her vitals were pretty elevated. Heart rate, blood pressure, her respirations were way too fast, and she did have a temperature. So moving on to the laboratory and diagnostic testing, since she came in complaining with severe chest pain and shortness of breath, there were a couple of tests that needed to be done to determine the cause of the pain, whether it be cardiac, respiratory, and they also had to make sure that her kidneys were functioning correctly. So the physician ordered a CBC, a BUN, creatinine, electrolytes, a blood culture, as well as an ABG, a D-dimer, a chest x-ray, an ECG, and a type and cross. Excuse me. The CBC is a view for all blood cells to check to see if she's anemic or if there's any sign of infection. The BUN and creatinine were to check her kidneys and her electrolytes to see if any of the problems were because of an imbalance there, whether she's dehydrated. A blood culture was also ordered because she was telling the nurse that she was coughing up, having a productive cough. Her ABGs to see the respiratory distress, the severity of it. A D-dimer was to check to see if there's any clots. A chest x-ray to see if she has any cardiomegaly or any consolidation infiltrates in her lungs. An ECG is also to see how her heart is functioning, and of course a type and cross. She's had previous occasions where she needed blood transfusions, so that was another thing ordered. So from her results, her CBC showed that she had an elevated white blood cell count, which can be seen as an infection, of course. Her hemoglobin and hematocrit were pretty low, which explains the pallor of her skin. And the platelets are slightly elevated, nothing too crazy. We also got the sodium, the electrolytes. The sodium and the potassium were pretty low, so that can be a sign of dehydration and could cause other complications down the road if not corrected. Her ABGs did show signs of respiratory acidosis with that pH of 7.22 and her CO2 at 50 with an oxygen saturation staying around 88%. There's an issue there, and that needs to be corrected. The chest x-ray did show signs of infiltrate at the base of her lungs, and with this white blood cell count being really high and the chest x-ray showing what it shows, they also got a blood culture. I'm going to change to the next slide, and it did show that she has Streptococcus pneumoniae in her lungs, so she does have pneumonia, which is the reason for the infiltrates. So with her other tests, the D-dimer determined that there were no clots. And her ECG was in normal range, as well as her BUN and creatinine. So there was no signs of any kidney damage or dysfunction. I'm going to move on to collaborative management. So the medications that were ordered included opioid pain medications, non-steroidal anti-inflammatory drugs, antibiotics, and to improve ventilation, they ordered oxygen. And she's also getting some IV fluids. So let's see. So they have her at 2 liters to improve her oxygen levels and try to keep that oxygen saturation in the high 90s. She was started on dextrose 5%, have normal saline to maintain adequate fluid balance, to return her to the electrolytes to normal. She also has normal saline running, because they are going to go ahead and do a simple blood transfusion. Due to the increased respiratory and effects and decreased hemoglobin and hematocrit, a simple blood transfusion is needed to improve her hemoglobin to at least a 10. A simple blood transfusion will get her out of her severe anemic state. She is also, again, on IV fluids to improve the electrolytes and keep her hydrated in the first 24 to 48 hours until oral fluids can be initiated once AG is ready to drink those fluids. She's also encouraged to use an incentive spirometer every 2 hours to prevent atelectasis, and it can also prevent any worsening acute chest syndrome. Let's see, so they also had the procedures. They did the chest x-ray to see the abnormalities in the lungs. They also went ahead and did a CT just to make sure there were no blood clots and no sign of a pulmonary embolus. Let's move on. So the only dietary thing that I was able to come up with was increased fluids, because we need that to increase the blood volume, and it still needs to have a consultation with the dietitian. So continuing on with it, we have the involved care. So there is, of course, going to be the nurse, the attending physician, hematologist, and respiratory therapy. So the nurse involved is just to do the all-over care of AG, and they gave the medications prescribed, teaching her how to avoid another crisis and prevent future infections, so we don't have to go into this acute chest syndrome and having to go through all these blood transfusions. There's also going to be, again, the attending physician, and they will give the orders that are involved in AG's care, evaluate labs as well. Hematologist will decide the treatment plan in the case of the blood transfusion. So in this scenario, she is consulting with her regular hematologist, the attending physician is, and he has treated her in the past. He knows what treatment plan works best for her recovery. Since she's had acute chest syndrome before, with pneumonia, he knows where to really start going on this path. We also need respiratory therapy to be involved in the treatment of acute chest syndrome from her diagnosis of pneumonia. And these individuals can collaborate and plan a care plan that will improve respirations and the recovery from her two diagnoses. AG has had a similar episode to these kind of crises in the past. Her regular hematologist, an attending physician, will set up a plan of care that will help with their assessment findings, as well as the nurse and respiratory therapy. Give all that information from previous, just so that they can have backup and understanding. So before AG can be discharged, her white blood cell count should return to almost normal with the help of prescribed antibiotics. Her vital signs also must be stable. We need to return the O2 to 95. The respirations should stay between 12 and 20. And her CO2 shouldn't go higher than a 42 or below 38. And the goal is to achieve a supplemental oxygen. To achieve the goal, we need the supplemental oxygen, pain medication, and a substantial amount of rest with intermediate activity in between. And the goal is to have her pain managed and the blood cells return to normal, and make sure there's no transfusion reaction, fluid overload, and to make sure that there's no signs of worsening acute chest syndrome and pneumonia. Okay, and that is my portion. Thank you.